Okay, thank you, Miss. Good morning, good afternoon to everyone. Before starting, let me thank the organizer for kindly inviting me to this so interesting meeting. Today, we will discuss about the recent advances linking obesity with breast cancer and endocrine resistance, particularly focusing on the molecular players involved in this harmful connection. As most of you in this audience already know, breast cancer represents the most commonly occurring malignancy and the first leading cause of cancer-associated deaths in women through the world, showing morbidity and mortality rates of 25% and 50% respectively. On basis of Globocount 2020 data, over 2 million new cases and 600,000 deaths have been estimated. Estrogen receptor positive breast malignancy that overlaps with luminal molecular subtypes account for 70–80% of all cancer cases, and these tumors, endocrine-based treatments with selective estrogen receptor modulators or degraders and aromatase inhibitors are of much therapeutic value both in the adjuvant and recurrent setting. The drugs of choice include the prototype of SERMs, tamoxifen, the SERD fulvestrant, and aromatase inhibitor anastrozole, letrozole, and dexamethasone, able to significantly lower serum estradiol concentration in postmenopausal patients. However, despite highly effective, the development of de novo acquired resistance to this treatment has become a major limitation. To date, several hallmarks of hormonal resistance have been proposed, and these may include estrogen receptor loss or mutation, activation of growth factor-mediated signaling pathways and second messenger systems, alteration in T-cell cycle checkpoint or in gene involved in apoptosis and senescence, alteration in epithelial mesenchymal transition and cancer stem cell activity. More recently, it was proven that a reduced response to these therapeutic treatments may rely not only on tumor cell intrinsic factors, but it is also dependent on the surrounding microenvironment and on the host characteristics. Indeed, studies have suggested obesity, in addition to promote breast cancer development and progression, represent a heavy waiver player driving breast cancer endocrine resistance. In this presentation, we will highlight the complex and incompletely elucidated link existing between obesity and resistance in breast cancer. First, we will define the obesity condition and summarize the evidence derived from population studies that outlines the implication of excessive adiposity on therapeutic management of patients. Then, we will focus on the role played by adipocytes in endocrine resistance, discussing both in vitro and in vivo research. Finally, we will address the molecular mechanism by which obesity-associated changes may limit the success of tamoxifen, fulvestrant, and aromatase inhibitors, underlining the main actors involved in this alarming connection. Obesity is a multifactorial metabolic disorder characterized by an imbalance in energy homeostasis, leading to abnormal accumulation in body weight. Although presenting some limitation, body mass index, BMI, is the most practical and widely chosen indicator for diagnosing obesity and for evaluating the occurrence of the negative health consequences associated with obesity among individuals. Indeed, according to the standard WHO definition, overweight refers to a BMI of 29.9 kilograms per square, and obesity to a BMI greater than 30 kilograms per square. Based on BMI criteria, it has been reported that in 2016, more than 1.9 billion world's adult population was overweight, and of these, over 600 million adults were obese. Specifically, the prevalence of obesity has tripled worldwide over the past 4 decades, and these upsetting rates are expected to increase in the future, posing a serious threat to healthcare practitioners and global health system. Obesity represents not only a major recognized risk factor for metabolic and cardiovascular disease, but it also accounts for nearly 1/3 of all new cancer diagnoses and for 50–20% of total cancer-related deaths. Indeed, there is expanding evidence showing a role for obesity as a contributor to several types of malignancy, including endometrial, prostate, colorectal, pancreatic, and breast carcinomas. Several clinical studies demonstrate that excessive adiposity may worsen the incidence, prognosis, and the mortality rate of breast cancer. Accordingly, obesity women were more likely to exhibit larger tumor size, lymph node involvement, higher propensity to distant metastasis, lower distant disease-free interval, and overall survival. Furthermore, overweight and obesity has been associated with increased risk of developing contralateral breast cancer or a secondary primary malignancy at other sites in women previously diagnosed with breast cancer. In the adjuvant setting, data are emerging on the lower benefits of anti-tumor therapies in obese women. Obesity is associated with a reduced effectiveness of chemotherapeutic agents, in part related to dose-limiting toxicity and undertreatment in obese patients. Increased risk of complications associated with all treatment modalities has also been described. On the other hand, the optimal use of endocrine treatments in obese women is still a topic of intensive research, since in the literature, data relating these therapeutic regimens, BMI, and outcomes are not conclusive. Different reports demonstrate that the effects of adjuvant treatment with endocrine therapy were poorer in obese women than in lean ones. Other studies revealed that higher BMI was associated with shorter recurrence-free and overall survival in patients treated with tamoxifen, but not in those receiving aromatase inhibitors alone. However, important trials showed that tamoxifen, raloxifene, and fulvestrant decreased breast cancer recurrence and mortality regardless of BMI. In addition, in the randomized double-blind arimidex tamoxifen alone or in combination trial with a 100-month median follow-up, it was found that tamoxifen was equally effective across all BMI levels, while the relative benefit of anastrozole was significantly lower in women with a high BMI. And this trend was confirmed by other studies. As opposite to non-steroidal aromatase inhibitors, in the neoadjuvant exemestane clinical trial, low BMI was found to be an independent, negative predictor of clinical response, with the most favorable outcome observed in the high BMI group. While in the TEAM trial, at 5.1 years of follow-up, BMI was not associated with risk of relapse in either arm. From this observation, we can argue that the dissimilarity in the published findings may be due to differences in patient populations, disease characteristics, treatment, analysis methods, and BMI categories, and this complex scenario may certainly limit the possibility to pull results together and to create generalized recommendations. Currently, a number of clinical trials are going to address this important issue. Mechanistically, several experimental studies have suggested the molecular link between obesity and endocrine resistance, particularly in relation to adipocytes. Indeed, in addition to their role on the systemic changes associated with obesity, adipocytes are progressively taking center stage in the context of tumor stroma-related studies. In the breast, cancer epithelial cells are immersed in a fatty environment, and heterotypic interaction between these two cellular types at the invasive tumor front have been shown to induce the proliferation, migration, invasion, and metabolic rewiring of different breast cancer models. A combination of direct co-culture and conditioning medium approaches has extensively demonstrated the existence of reciprocal and functional signals. Indeed, tumor cells are able to shape the fate of adipocytes by altering their gene expression as well as signaling factor separation, and the so-called cancer associated adipocytes, as a consequence of their closely localization, could promote tumor aggressiveness. However, up to now, only few reports have applied such experimental design to bring out the influence of this dialogue on endocrine treatment resistance. For instance, it has been found that co-culturing MCF7 breast cancer cells with mammary adipocytes obtained from obese women or exposed to high glucose resulted in decreased tamoxifen responsiveness. Conditioned medium collected from obese adipose stem cells treated with letrozole was able to induce proliferation of breast cancer cells as compared to that collected from lean adipose stem cells. Obese mice exhibited greater tumor growth rates, diminished response to letrozole, and quicker acquired resistance than lean mice. Furthermore, by grafting patient-derived estrogen receptor-positive tumors into mice that are susceptible to diet-induced obesity, it was observed that obese environment potentiated the growth of estrogen receptor-positive tumors and sustained tumor progression after estrogen withdrawal. Nevertheless, most of the studies that attempt to unravel the molecular mechanism explaining the impact of obesity on sensitivity to hormonal therapy have been focused on the role of individual molecules within adipocyte secretome panel. Indeed, the pathological expansion of white adipose tissue in obesity leads to a development of a dysfunctional adipose tissue, which is associated with imbalance in adipokine pathophysiology, abnormality in the IGF-1 system and signaling, a state of chronic low-grade inflammation and oxidative stress, increased estrogen biosynthesis and pathway, release of metabolic substrate and extracellular matrix molecules. These host extrinsic factors interact with several breast cancer cell intrinsic signalings to significantly impact growth and survival, metabolic reprogramming, local invasion, and metastatic spread of breast cancer cells during endocrine treatments. The dysfunctional adipose tissue produces a series of bioactive peptides named as adipokines. At present, more than 100 different adipokines have been identified, and among them, leptin has been the most intensively studied molecules for its influence on breast cancer progression and therapy response. A growing body of evidence has clearly shown that leptin, secreted by peritumoral and distant adipocytes in proportion to fat mass, binds to its own receptors expressed in breast cancer cells and interacts with multiple oncogenic signalings. This leads to the activation of various signaling transduction pathways that are known to function as key determinants of tumor progression in spite of endocrine treatments. Obesity and its connected metabolic syndrome generate an environment characterized by enhanced circulating levels of insulin and its related growth factors, especially IGF-1. Indeed, tumor cells expressed the receptor for IGF-1, a binding to their own ligand, primes receptor itophosphorylation, phosphorylation of downstream signaling, such as RS1 proteins, and activation of a number of downstream kinases that promote endocrine resistance in breast cancer cells. IGF-1 receptor and insulin receptor crosstalk represents another mechanism of escape from hormone dependency. IGF-1 receptor activation by IGF-2 regulates basal ligand-activated AGF-1 receptor and cell proliferation in a CSART-dependent manner in resistant cells. And androgen receptor and estrogen receptor functionally collaborate to induce resistance via activation of IGF-1 receptor and PI3 kinase pathways. However, although this concept, the clinical studies have failed to ascertain a significant effect of IGF-1 receptor inhibition in therapeutic settings. Perhaps a more comprehensive strategy of targeting IGF-1 receptor network and a more accurate selection of patients could be the avenue to harness. One of the most important features behind the link existing between obesity and breast cancer endocrine resistance is the low-grade chronic inflammation due to the release of several inflammatory mediators from both the tissue-resident cells as well as from immunocells within those tissues, mainly macrophages. Adipose tissue of lean people is characterized by a small number of macrophages, while this number rises in that of obese individuals, and the degree of infiltration has been significantly correlated with tumor sites, recurrence, obesity, and development of tamoxifen resistance. An increase in adipose tissue macrophage may result in the formation of crown-like structure, and the CLC index ratio from individuals with obesity seems to influence breast cancer recurrence rates, survival, and therapy response. Adipocyte macrophage interactions has been shown to lead to activation of the pro-inflammatory NF-κB, an important event associated with a reduced cell response to estrogen withdrawal, tamoxifen, and fulvestrant treatments. Obesity is known to induce adipose breast tissue hypoxia that has been proposed to play a critical role in both inflammation and therapy failure. Adipokine dysregulation arising during obesity is also important in terms of adipose tissue inflammation. For instance, leptin impacts the phenotype and the function of immunocells, including macrophages, to stimulate chemiotaxis and the secretion of additional inflammatory cytokines. Thus, obesity may potentially fuel resistant to endocrine therapeutic treatments via systemic and local overproduction of several pro-inflammatory molecules, and a list of these major obesity-associated mediators is provided in the table shown in these slides. Adipose tissue, being an endocrine organ, can regulate the production and bioavailability of sex hormones, which can mediate the association of obesity with reduced endocrine response, mainly aromatase inhibitors. Indeed, adipocytes strongly express aromatase that is responsible of increased estrogen biosynthesis. Consequently, excessive fat mass may impact both circulating and locally secreted estrogen concentration in breast tumors. In breast cancer cells, leptin, insulin-like growth factor, prostaglandin, tumor necrosis factor alpha, and interleukin-1 beta, by the binding with their own receptors, could stimulate aromatase gene expression and enzymatic activity in breast cancer cells via transcription regulatory mechanism. We have also demonstrated that aromatase activity is amplified by estradiol at post-transcriptional levels through an increase of tyrosine protein phosphorylation mediated by an enhanced crosstalk with growth factor and the tyrosine kinase C-cell translational signalings, and an activation of PI3 kinase AKT pathway and a subsequent inhibition of the tyrosine phosphatase PTP1B catalytic activity that impair the enzymatic ability to dephosphorylate aromatase has been also reported by our research group. These events lead to increased aromatase expression activity, estrogen production viability, and estrogen receptor activity. Therefore, by highlighting the different molecular mechanisms involved in aromatase regulation and breast malignancy in the context of obesity, current research may suggest the importance to refocusing existing treatment strategies based on the rationale to personalize the dose of aromatase inhibitors required to maximally suppress estrogen production and improve clinical benefit of obese women. Breast adipose tissue is also a source of free fatty acid and cholesterol required for energy and building blocks to support abnormally increased proliferation of cancer cells. Recent studies have outlined lipid metabolism-related threats as key enablers of resistant to endocrine therapies. For instance, it has been demonstrated that cholesterol and this biosynthetic precursor mevalonate through the activation of ERR alpha pathway can trigger an intense metabolic switching, propagation of cancer, stem cell-like aggressiveness, and the resistance to tamoxifen treatment in breast cancer. In line with different observations, multiple studies demonstrated the potential utility of statins in breast cancers. Finally, it has been shown that adipocytes and adipocyte-derived stromal cells may secrete extracellular matrix molecules that hold a major role in regulating breast cancer cell fate, signaling capacity, and therapy resistance. In this regard, it has been demonstrated that estrogen receptor positive cells cultured on ECM matrix exhibited estrogen-dependent growth and reduced sensitivity to estrogen receptor target therapies. Fibronectin also protected epithelial cells against tamoxifen-induced cell death, and clinically, expression profiling study discovered an ECM gene cluster of 6 genes, which was overexpressed in patients with resistant metastatic disease. Certainly, further clinical validation and functional studies of the dynamic interaction between ECM proteins and tumor cells may help to address the clinical issue of endocrine resistance, providing potential signature for treatment decision and suitable druggable targets for therapeutic intervention. In summary, just to give you a brief abstract of this story, we can conclude that the mechanisms behind the interplay between obesity and endocrine therapy resistance are likely to be multifunctional. breast cancer is exposed to a different milieu, dramatically changing during the development of obesity, and lessons learned from obesity and cancer research propose important mediators such as adipokine, IGF-1 pathway, inflammatory cytokines, aromatase activity, lipid metabolism, hypoxia, and oxidative stress that are all abnormally modified in obese women. These obesity responsive factors stimulate hyperactivation of several cancer cell intrinsic signalings and transcriptional factors, which may render breast cancer cells refractory to endocrine treatment. Given the escalating global epidemic of obesity, advances in understanding this critical node will offer new precision medicine-based therapeutic interventions and more appropriate dosing schedule for treating obese patients with breast tumors resistant to endocrine therapies. Most importantly, being excess BMI, a commonly acceptable modifiable risk factors, multiple opportunities for primary to tertiary prevention should be considered as a priority area of action. Before ending, let me thank the research lab members at the Department of Pharmacy, Health and Nutritional Science at University of Calabria, and of course, thanks to all of you for your so kind attention. Thank you for your attention.
Oh, thank you, Dr. Ines Barone, for your wonderful talk on breast cancer. So I just want to ask the panelists, is open for discussion. If there is anyone with doubts, you can please ask Dr. Barone.
Hello, thank you. Can I ask a question?
Of course.
Thank you very much for a nice presentation. As far as I understood, what you're implying that there's really a thin layer between being obese and basically having a cancer responsible for the treatment, right? So what you're implying
that please, because I couldn't hear you so well, sorry.
Okay, I'll try to increase the volume meanwhile.
Thank you.
Yes, can you hear it better now?
Yeah.
Okay, I started out saying that thank you very much for the nice presentation.
Thank you.
As I understood, if I can simplify it, so you are saying that there's a very thin layer between being kind of an obese with a cancer and responsible for the classical like endocrine responsive treatment, right?
Yes.
So what about, because often the case is that you are having intermediate ones. They're not really an obese, but you wouldn't, because we also know that being not obese or extremely slim is a problem because you lack estrogen, right? What happens? Yeah. Do you have any idea about what happens in that case?
You mean for the overweight people?
Overweight people plus those that basically extremely slim people, you know, this Popeye's wife kind of, they lack estrogen, right? After menopause, especially. What happens in that case? Do you have any experience?
It depends from the study, because some study compare just the obese population to what they consider normal or healthy weight. Other study put the overweight and obese population together, and they still have this significant difference between response to therapy. Considering people having less weight, I mean, it depends, because even some study, they just consider people less than 24 plus 9 kilograms per meter square, and they don't specify just in the healthy weight, healthy normal window, or even less. And even in this study, there is this difference. But there are no, for my knowledge, selective study that considered, I mean, a population with a BMI less than 19 kilogram per meter square. Because
Okay.
I mean, most probably there is not so a huge population, maybe for statistical significance, with does generally some study pull together these people.
Yeah, so your results in line with that. What we know, if you have less fat layer, you are lack of estrogen, but that does not really interfere with the response to treatment. That's what you're saying, right? So it's not the estrogen level, it's the fat layer.
It's a
amount
fact,
of
because I mean,
yeah.
the fat
Okay.
contributes with estrogen, so maybe this can be the lower response for aromatase inhibitor, but fat produce also growth factor, inflammatory mediators such cytokines, so there are a huge factor that can overlap in the action, and the main problem is that maybe in some subjects can be more predominant the IGF-1 signaling, in other subjects maybe the inflammation can be more predominant, so it's a really difficult population to understand.
Yeah. Okay. Thank you very much. Thank you.
Thank